Good morning, everybody. So I'm going to continue talking about alterations in the immune response, and I have taken out HIV and AIDS from this PowerPoint because I think it will be too much information to have in one slide. There's a lot of information in here that you definitely do not have to know, and as I go along, I'll basically highlight the most important information for you for right now. It is a good reference in terms of a slide to have for later on when you're studying for the NCLEX, let's say. But some of the stuff we don't need to know because it's really, really detailed. So I'll highlight what you need to know. So we're talking about immunodeficiency disorders. We're talking about some of them being primary versus some of them being secondary. And then the latter part of the slides will go into some of the immunosuppressive therapy that is available out there. The immunodeficiency disorders can basically be described as either being primary or secondary. So why does this happen? So it's when the immune response does not adequately protect the body. Then you have what is known as an immunodeficiency. So we've already talked about, what our immune system is supposed to be doing, right? And we've talked about, the humoral response versus the cell-mediated response, all of that. So at this point, you're trying to put everything together and make sense of everything. So when it comes to immunodeficiency disorders, there's usually an impairment of one or more areas of the immune mechanisms, and there are so many different types of immune mechanisms. So you've been given an example of all of those here. So in particular, we highlighted phagocytosis when we were talking about the immune system. We talked about the humoral response. We talked about the cell-mediated response. Those were the ones that we highlighted. But here you've been given other different types as well. All right, so just know that these are also here. So by definition, an immunodeficiency disorder is primary if the immune cells are improperly developed or absent. So that's the key word. So it's primary if the immune cells themselves are improperly developed or they're absent. So from the get-go, it's something with your development from the very beginning. So that's the issue. So they've just been given examples here of what that could look like. And you've been told that specifically when it's a primary immunodeficiency disorder, it's usually genetic. So you've been given examples of that. And you may be familiar with some bubble babies that are born without any adequate immune system, and they have to be kept in a bubble because every little thing is a threat to their body. And then you've been given some other types of examples. So for your purposes, just know that there's primary and there's secondary immunodeficiencies, and that the primary one are usually genetic, and it's usually because the immune cells are improperly developed or they're absent. That's the main takeaway from here. For the secondary immunodeficiencies, so they are usually caused by illness or treatment, and you've been given some examples of why somebody could end up having a compromised immune system. So some of these you're familiar with. So things like medications, those are like your most common cause, right? Things like aging. So people, like when people are older, their immune system is not functioning as well. Or even babies, when they're born, they don't have an intact immune system, right? And they're relying on hopefully the mother breastfeeding them so that they can start building up some type of immune system at some point. Other causes for secondary immunodeficiency disorders. So your diet, malnutrition, cachexia is wasting syndrome, dietary deficiencies, things like therapies like radiation, surgery. We've talked about, you can live without a spleen, but that puts you at risk, right, for infections, and your immune system is not as strong. So going under anesthesia, all of that puts you to sleep, knocks you out. Your immune system is not functioning as well as it should be. Stress for sure, especially chronic stress, right? All of these could be considered secondary um, factors that can impact your immune system. We have other conditions here. So we have things like diseases in particular, AIDS, that goes without saying, cirrhosis, chronic kidney disease, any type of malignancy, and so in particular cancers, right? Things like lupus erythematosus, and these are considered, systemic lupus erythematosis in particular is considered an autoimmune disorder, right? Burns, so they're causing a lot of shock to your body, even trauma, severe infection. All of these things are destroying your normal coping mechanisms in some way. You're stressed in some way. So everything kind of makes sense and everything ties in pretty nicely. All right, so main takeaway, you have immunodeficiency disorders, you know that they can be primary, those are considered genetic, and you know that they can be secondary, and there's a whole bunch of different things that can cause your secondary immunodeficiency disorders. We're now going to talk about transfusion and organ transplant reactions, and we'll once again highlight what is important for us here. So there are many different types of indications for somebody to be getting blood and blood product transfusions, right? So some of them have to do with the fact that maybe the patient has severe anemia or has symptomatic anemia. So symptomatic anemia basically just means that they're exhibiting some signs and symptoms, right? So maybe they're fatigued, like extremely fatigued, right? You've probably know people who are anemic. And you know that they're exhausted half the time. They can't, when they're trying to climb up the stairs and they can't breathe, something like that, to the point that it's affecting their activities of daily living, right? It could be that the patient knows that they're going to need a blood transfusions at a later date. So that would come in under auto transfusion. Let's say somebody was recently diagnosed with cancer, and depending on the type of cancer that they have, they know that at some point down the road they are going to need a blood transfusion, and they don't necessarily want to be getting blood transfusions from anybody else. So before the cancer gets really, really advanced, they may actually take their own blood, like give their own blood, and it's maybe in the form of frozen red blood cells, and they can store that. And this is a situation where they can actually store their RBCs for actually a very long time. Some sources will say that they can keep that stored away for as long as, even as long as 10 years in some instances, so 10 years. And so when they're ready, then they just have to, they can unpack that and throw it out, and then they can use it. So the different indications for when somebody may need blood products. So anemia was one of them, autotransfusion for later on, bleeding, thrombocytopenia, deficiencies in clotting factors, all of that, right? And none of this should be weird for you. All of this is making sense at this point. So we have a test known as an ABO test that will show what type of blood type a person has. So even with the blood typing here, guys, you're going to keep it very simple. There is a chart later on that tries to organize all of this information for you. You're not responsible for memorizing how many people in the population have which type of blood type, etc. That's for your purposes right now. That's not important. It's much more important for you to know, okay, what type of blood does a person have? So very simply, if you have the A antigen, you have type A blood, right? So the liquid portion of your blood, the plasma, has antibodies that fight against type B blood. That's the takeaway. If you have the B antigen, you have type B blood. So your plasma has antibodies that fight against the type A blood. If you have neither, if you have neither the A nor the B antigen, so you have no antigens essentially, you have type O blood. Your plasma has antibodies that fight against both type A and type B blood. If you have both the A and the B antigens, you have type AB blood. Your plasma does not have antibodies against type A or type B blood. Otherwise, if it did, then it would kill, you'd kill yourself off. So that wouldn't make sense. And right off the bat, from the very beginning, you need to know that type O is considered the universal donor, and type AB blood is considered the universal recipient. So this is a terminology that you want to start becoming familiar with right away. Okay, so the stuff that's in red here is in red for a reason, because it's important in terms of your nursing care. So blood received in a transfusion must have the same antigens as yours. So it has to be compatible. If you get a transfusion that has different antigens, that's considered incompatible blood. The antibodies in your plasma will destroy the donor blood cells. This is called a transfusion reaction, and it occurs immediately when incompatible blood is transfused. A transfusion reaction can be mild or can be serious, and it can even cause death. All right. So type O negative blood does not have any antigens. It is called the universal donor because it is compatible with any blood type. Okay. And then type AB positive blood is called the universal recipient because a person who has it can receive blood of any type. So even though we're using terms like universal donor and universal recipient, you still have to make sure that all the blood typing that needs to be done has been done to prevent any type of transfusion reactions. Because in emergencies, you go and grab type O blood if that's what's needed, or type AB blood if that's what's needed, but you still want to make sure that all the cross-matching typing and screening has been done for sure. Then there are other minor antigens that do exist, in particular RH, but we're not getting into this at this point. You may have come across this when you were doing PEDS. Okay, so this is the same information, and it's presented for you in chart formation. So you just want to know which blood can which person get. Basically, at the end of the day, you're looking at that last, or you're looking at the whole chart, but you're trying to just get familiar with the last square in the bottom here. You're looking at over here, like in terms of the antigens. Are there antigens present? So therefore, if they have antigens, which blood can they get, can they not get? Who's the universal donor? Who's the universal recipient? You're kind of looking here. You're making this as easy for yourself as you can, and there's not much I can do in terms of helping you. You have to memorize it. So when a patient is getting a transfusion, there are certain things that can be problematic for the patients, right? And so there are many different things that come into play. So bacteria is one thing. So when the patients are getting blood transfusions, making sure that you're doing this properly. Are there other types of pathogens that could become risk factors for the patient? Are there types of leukocytes that maybe when the patient is getting has gotten a transfusion, that maybe your body won't like the leukocytes and it was going to fight it off, maybe in some cases, or even the fact that you're getting the leukocytes, but then the leukocytes are attacking you. So it's just all these different things that you have to take into consideration. You're not overthinking the slide. You're just knowing that there's certain risks to the patient when they're getting a blood transfusion, and therefore you are making sure that all of this has been factored in already. And this is not necessarily your job, because the person that's determining what bloods to give is the person that's probably going to be thinking about all of these different aspects. Like maybe the screening, though, you're part of that, because you have to make sure that the typing screen was done. And when you're giving the blood, you have to make sure that the match is available. So that's why you're having two other nurses kind of checking this with you. Right? But we just want to make sure that the proper testing has been done and no blood is contaminated. You're calling for the blood when it's time. You're not calling for the blood 5 hours ahead of time, and you don't even have an IV line in place, and then the blood is just sitting there and just going bad or clotting or something weird like that. So just making sure that you've really you've made sure that there is an IV in place, you've made sure that the blood has been typed and crossed, and when the blood does arrive, that you have a set of vitals beforehand, before you start, like all of those different things. Connecting the IV properly, you have the tubing for the blood and the normal saline, all of that stuff, right? To make sure that you're not going to end up with a reaction or sepsis at the end of the day because you weren't connecting all of this properly. So there are blood transfusion reactions that can happen. So by definition, a blood transfusion reaction is an adverse reaction to blood transfusion, and it can basically range from mild symptoms to life-threatening conditions. And some of these blood transfusion reactions can be classified as an acute reaction versus a delayed reaction. So just know that this exists. It can be acute and it can be delayed. Okay. So for your acute transfusion reactions, they can be described as acute hemolytic reactions, and these are usually because of the blood type incompatibilities. So somebody didn't do the checking properly like they should have, all right? Some of the transfusion reactions are considered febrile reactions. So these are considered non-hemolytic, but they are what's going to happen is that the patient's going to have like a temperature. So it's associated with a fever, and it's not necessarily a hemolytic. So that's why you're checking your vitals. You're checking all of that because any fluctuation in temperature has to alert you to something for more diligent monitoring, right? Because different reactions will show themselves in different ways. And then the other type is the allergic reactions. The recipient is sensitive to plasma proteins of the donor's blood, right? So know that these reactions are out there under acute and that they can happen. So acute reactions can also be the result of fluid and circulatory overload, sepsis, or the result of too much blood being transfused. So what are you going to do when somebody is showing up with an acute transfusion reaction? Well, so this is your emergency management right away. You're going to stop the transfusion. You're going to maintain a patent IV line. And what you're going to do is you're going to literally just take everything off, everything that was infusing. Because normally what you have during a blood transfusion is you have two bags at the top hanging. One is blood and one is normal saline, right? And then all of that gets connected. It goes through the pump, and then you end up with a catheter going into the patient at the port, right? So what you normally do is before you start the blood transfusion, you would first start of course you'd have primed it, all of that good stuff, right? You would first start the normal saline, infuse that for a little bit, right? And everything is good. And then when you're ready, you've done your vitals, etc. You'd clamp off the normal saline, and at this point you would infuse the blood, right? And you're with the patient for that, especially for those first 15 minutes. You're not going anywhere. You're taking your vitals. You're making sure that you're diligently monitoring everything because of the potential for a transfusion reaction. The reaction happens. You have to stop it, right? And you have to basically disconnect the catheter from the patient. You wouldn't When they're saying maintain a patent IV line, they want you to hang normal saline, but you wouldn't, let's say, stop the blood and then again restart your normal saline that you already had hanging using the same tubing, because the patient would have been getting blood. And if you stop the blood and then now restart the normal saline, in order for the normal saline to infuse through, the blood that was already in the tubing would have to go first, and then your normal saline would infuse. So that's a no-no, that's a problem. So you are going to disconnect everything. All right, you're going to disconnect everything, and then you're going to get a fresh tubing with fresh normal saline, and then you are going to infuse that. All right, so stop, disconnect everything. You're not throwing it away, because everything has to go back to the blood bank, because they have to analyze everything, they have to look at it, and they have to determine what type of reaction happened, um, based on analyzing the blood as well as the information that they get from you. That's why you're monitoring the patient. Did they have a temperature? Did blood pressure change, etc.? Did they get hives? Whatever it is. All right. You're notifying the blood bank and the healthcare provider immediately. You're rechecking the identification tags because you're trying to figure out, okay, where did I go wrong? You're monitoring the vital signs and your urinary output. You're monitoring urinary output because the patient could go into shock, and that is a really, really severe reaction. Like the kidneys can literally shut off. So that would be like the worst reaction that can potentially happen along with that, right? Um, you're saving the blood bag and tubing, and you're sending everything back to the blood bank, and you are documenting. And then you may be given orders, of course, like to give them medications, whatever that follows after that. And the blood bank is responsible for identifying the type of reaction, like I said. Okay, so notice you are not running and calling the blood bank or calling the healthcare provider first. First, you are stopping the transfusion, disconnecting everything, and then you are maintaining a patent IV line. Because most likely, once you call the doctor, they may tell you, okay, the patient's going into shock potentially. We need to give fluids, whatever, right? Because by you making a phone call first, you're wasting time, and you don't want that, because as you're trying to call the doctor, blood is still being transfused into the patient. Okay? So this is just something to be aware of here. So this is just a picture also talking about what the nurse is doing. So your patient is calling for help, because maybe you were there for the first 15 minutes and nothing happened, and you went away to do some other stuff, right? Because blood transfusion sometimes can be over 2 hours or even longer in some cases. So you've stayed with the time that you're supposed to be there, nothing went on, everything was good, but then maybe you went away to do some other stuff, look at your other patients, because you're not going to sit there for 4 hours, right? And 4 hours, I'm exaggerating, that's a long time. Let's say 2 hours. But and then Jay screaming all of a sudden, right? So you're lucky Jay can scream. What if your patient was comatose and they couldn't, right? So there's just so many different types of scenarios that can happen. But either way, you're going to come in and you're shutting off the you're doing here assessing quickly, and then you're shutting it off, taking everything off, and then you're going to hang your normal saline, and you're doing your vitals, and you're sending blood tubing, etc., all of that stuff back to the blood bank, right? And then so notifying the doctor is third, right, after you've done all the emergency interventions right away. All right. So that was under your acute types of blood reactions that can happen right away, right? And then you have what are known as delayed transfusion reactions. So they could be because of delayed hemolytic reactions, and they could also be because of different types of infections that are going on. So just know that there is a potential to have delayed transfusion reactions, and there are different conditions that can cause that. We're now going to talk about we are talking about organ transplants and rejections here. So primarily your organs can come from two sources, either living donors, which is your family members, or they're deceased donors, so people who've passed. And this is the majority of organs for transplantation. They're coming from people who have passed on. So, we all know that we can be organ donors, right? So this is a decision that you can make now, and when the time comes, your organs can be used to help somebody else. So that's just something to think about. It is an ethical I don't know. I don't know if it's an ethical dilemma, but it's well, it's a decision that basically you have to think about while you are alive as to whether or not you are going to be an organ donor. There are different cultures that don't believe in donating their organs at all. They feel that, you come in as a whole person, you should go out as a whole person. And then there are other cultures that believe that, if you are an organ donor, maybe the healthcare system is not going to work as hard to save your life, when you are, let's say, going into shock or being resuscitated. They feel that if healthcare providers know that you're an organ donor, that maybe they won't do as much to save your life, and then they'll want to give your organ to other people. So there's mistrust of the healthcare delivery system. So these are just different aspects of this that I would like you to be aware of, because you may get questions sometimes even on the NCLEX having to do with just different cultures and how they perceive the healthcare system and how you would deal with all of that, right? Because then you'd have to do some teaching that ideally that's not what the healthcare system is about. But at the end of the day, you can't force people to make that decision. And I had a situation with this that I remember. I was young. I wasn't a nurse yet. I was young, but my youngest brother, was actually killed in a car accident. And we had just moved to the United States at that time, and he was crossing the street running, as kids do, and he was hit by a cab and ended up at Mount Sinai. And I remember this to this day because as my brother's brain is swollen, we're in the ICU. I tear up just thinking about it. People from organ donation came to talk to my mom and my dad. And my mom and my dad, new to this country, don't even know anything. That to me wasn't the time actually to be speaking to family members about something like that. And, they eventually made the decision that they were going to, donate his organs. But at the time, they didn't even allow you to know where your organs would be going. Or if they did allow it, my parents weren't given all the information that they probably should have had. And I think different things are in place now where they protect family members from that type of intrusion. But don't be surprised that this may happen on some units, and you would have to be a patient advocate to see whether or not that's the right time for them to be doing, that type of discussion. So like we don't know where his organs ended up, but that memory stays with me to this day because I do remember him, being really sick. I remember the people coming, talking to my parents, and when you don't know, I guess you don't know. I don't even know if they knew that they had an option to say no, right? So just be aware of that. Okay. Okay, so I can never talk about this without just getting emotional. It just brings up a whole bunch of things for me. Anyway, so what do we have to do? So we have to match the organ donor to the recipient, and we have to make sure that we've done an aggressive assessment and that everything that needs to be in place is in place. And there are different things basically that we have to take into account. So we're doing the ABO blood typing. We're looking for the HLA typing, so the human leukocyte antigen here. So this is really, really important. You're going to hear about HLA all the time. So HLA antigen regulates the immune system in humans, and it's something that you're looking at when you're matching the organ tissue, when you're matching the organ that the patient is getting and the patient's own tissue to make sure that they're compatible, right? So making sure that organ tissue and the patient's are compatible in terms of their leukocyte antigen and that there won't be some weird reaction here. You're looking for any preformed cytotoxic antibodies. You're looking at the medical urgency, how soon do they need to get this transplant done. You're looking at how long they've been on the waiting list. and you're looking at the geographical location. How far is it to get to where the patient might be? How far is it to get the organ to that patient, etc. So there's a whole board pretty much at each institution that specifically deals with who is going to be getting an organ, who is not. They look at all of this as an ethical decision making board, because obviously other people with money can always get ahead of everybody else. And even with the current COVID crisis, like, athletes are getting tested much more than anybody else is in the community. So this is just a board that will be available to basically look to see if everything is being done appropriately, and everybody's getting a fair shot to get organs. So in terms of organ transplant and rejection, there are other types of rejections that I want you to be aware of. So there's what is known as a graft versus host rejection that can happen, right? So this occurs when the immunocompetent or immunodeficient patient is transfused or transplanted with immunocompetent cells. So let's say I am immunocompromised. I don't have a very strong bone marrow. Let's say it's weak, it's bad. So it's been determined that they're going to give me a bone marrow transplant. So this is going to be a healthy and a strong bone marrow that they're giving me, right? So what happens is when they give me that healthy new bone marrow, what will happen in a graft versus host is that the graft, which is the bone marrow that they're giving me, is going to attack me, the patient. It's going to attack the host. The graft is healthy, it's strong, it's good. It's going to attack the host. It's unhappy with the environment. It sees everything as bad. And the T cells, so these are healthy, strong T cells that are in the graft, are basically going to attack the host because they're seeing them as weak, as dirty, as whatever. So this is one type of rejection that can happen. And then we'll talk about the typical type later on, and I think in a couple of slides. But I do want you to be aware of this particular type of reaction that can happen. So the donated graft sees the recipient, the host, basically as foreign, and it rejects it, and it gets upset. So can also result from the infusion of blood or blood products containing viable lymphocytes, and or the transplantation of fetal liver, thymus, or bone marrow. So it happens in any of these target organs like the skin, the GI tract, or the liver. Any of these areas may be affected. Okay. The major difference between a graft versus host disease and a typical transplant rejection is that the graft rejects the host or the recipient. And I've already mentioned to you that the donor T cells are involved. This is, if you remember, your donor T cells are part of your cell-mediated immunity. So they're basically trying to protect you, though, right? They're working, they're doing what they're supposed to do. So they go on offensive and they attack the host tissue, or they attack anything that looks bizarre. So it can happen anywhere from 7 to 30 days after transplant. Once the reaction is started, it can't be stopped, or the better word is that it's very difficult to treat. So once this chain of events starts, it is incredibly difficult to treat. So what they usually do is they make sure that before they give you that graft, before they give you that whatever tissue they want to give you or blood they want to give you, that they are preventative. You have to have preventative measures. So either they're going to immunosuppress you, the host, to make sure that your immune system is not going to be acting weird. They'll make you as weak as they possibly can, or they'll treat the graft itself. So what they'll do is maybe they'll take out some donor T cells from the graft. They'll clean out that graft as much as they can so that when they transplant it, this reaction won't be going on. So that's where the radiation to blood and blood products can come in. In other words, they're treating whatever the graft is before they give it to you, because like I mentioned, it's incredibly difficult to stop the reaction once it starts, because those T cells are going to kick into gear and do whatever they can. So either the patient gets, so it could be a combination of everything. The patient becomes immunosuppressed. They've treated the graft itself. They've taken out T cells, because what they want to do is to make sure that that graft is going to take and it's going to stick around. Some of the manifestations you're going to see, so rash here, pruritic, could be pruritic, painful on the palms or the soles of the feet. Any of this is possible. Okay. More manifestations. So liver can have jaundice with elevated liver enzymes to hepatic coma. So all of that can happen. Intestinal manifestations, mild to severe diarrhea, severe abdominal pain, GI bleeding. So yeah, look at these manifestations. Things like GI bleeding, hard to handle, right? And then you can get infections as well. Fungal and respiratory infections can also manifest. Okay. So your typical transplant rejection. So this is when your body rejects the organ. So this is the one that we're typically familiar with. So your body rejects the organ that they've given you. Okay. So organs rejected if the donor organ does not perfectly match the recipient's HLA. So somebody maybe didn't do the testing properly, and they didn't they didn't do all the checking that they should have done. So this can be prevented. So this type of rejection can be prevented by closely matching the ABO, RH, and HLAs between donors and recipients. So this is completely preventable, right? They do make a point of saying that a perfect match is nearly impossible, because I guess everybody's body is different, right? They're going to get the match as closely as they can. So there is always that risk, which is why when you've given the patient, if I'm sick, I need a new lung. I've gotten a new lung. We'll do everything we can for me to keep that new lung and for me not to reject it. So they'll give me immunosuppressives, etc. Okay. So this type of rejection is really important when you're giving heart and lung transplants. Apparently, it's not a typical reaction in liver transplantation. So you really have to make sure that you're doing the HLA matching for heart and lung transplants in particular. The time and distance can result in damage to the donor organ. So you just want to know how quickly this has to just is speaking to the fact that you want to get the freshly harvested organ. If you freshly harvested it, you put it on ice as early and as quickly as possible to the patient that needs it. How far away are you? How quickly are you doing the transplant? So this is what this is speaking to here as well. Okay, so your transplant rejections can also be described in different ways. So they can be hyperacute rejections. They happen right away, so within minutes to hours after the transplantation has happened. So this can have to do with the humoral response that gets instigated. So they may say, so a hyperacute is pretty bad. Like right away that this is not working, right? Like severely know that this is not working for the patient. So they will say that there's no treatment. I asterisk that because really the treatment is you just get rid of the tissue that you gave, right? So if within minutes or hours your body is rejecting whatever you got, right? You're getting this weird reaction going on, you have to get rid of it, right? Otherwise, can possibly do immunosuppressive medications, etc. But meanwhile, your body is rejecting everything, so that's not going to work at all. So some books will say that there's no treatment, meaning that you just have to get rid of the tissue that was given or whatever thing you were doing. All right. This is rare though because of careful cross-matching. Like no one should be getting a hyperacute rejection if the matching is done properly. But we did say there's no such thing as a perfect match at the end of the day, right? So still, it's rare. So what if you are that rare person that this happens to, right? So still, you want to make sure you're monitoring for this. And for all of these guys, like, so we're going to talk about hyperacute, acute rejection, and then chronic rejection. I'm not expecting you to memorize these. Just know that they're out there, but have a sense of what may be happening in each one of them. For the acute rejection, apparently it can happen days to months after transplantation. And here specifically, it's the T cytotoxic lymphocytes that are involved. And it can be reversible with additional immunosuppressants. But of course, your patient is going to be at risk for infection. With the chronic rejection, it can happen over months or years. It is irreversible. The organ would have been infiltrated with large number of T and B cells, and apparently this one can be common in lung transplantation, and it's also difficult to manage, and the patient ends back on the transplant list. So once again, just know that these types of rejections are out there. You don't have to memorize the specifics of it. And now we talk about just the immunosuppressive therapy that is available for patients, right? So this is just to suppress the immune response to prevent rejection of the transplanted organ while maintaining sufficient immunity to prevent overwhelming infection. So that's a tall order, and it may be difficult. So what are they doing? So once you've gotten this immunosuppressive therapy, of course, you're at increased risk of infection, and you're at increased risk of malignancies, different types of cancers for sure. So different things that they can use for immunosuppressive therapy. So obviously your corticosteroids, which you guys are very, very familiar with already, and your medications are you're familiar with these meds already. So with the steroids, they're inhibiting production and T cell activation and proliferation. So essentially suppressing the inflammatory response. So these are all your side effects that can happen, and you guys are already familiar with these side effects from steroids. Okay, and then they have other groups here: calcineurin inhibitors. Act on T helper cells to prevent production and release of cytokines, inhibits production of T cytotoxic lymphocytes and B cells. Other meds here, your cyclosporin, Sosandi Immune, Neoroid, Gengraph. So these are just examples once again, and look at the side effects. So big medications, right? Nephrotoxicity, that's not a little thing. Hepatotoxicity, yeah, lymphoma, right? That's cancer. These are like big side effects that can happen. So immunity is a big topic, and it's a specialized area, and they would never dump a new grad or even just a regular patient, a regular nurse on this floor, right? Because there's so many nuances and so many things that you have to pay attention to. Most likely, if you're on a regular floor, you may get a patient maybe, I don't know, weeks later after they've had a transplant, and maybe now they're on your floor after they're stable for sure. You're not going to be getting them when they're at increased risk for everything.